Hello, and welcome to the Thompson Hine Brown Bag Webinar Series. My name's Kim Wilcoxon, and I'm joined today by David Whaley, who will be monitoring your questions and chiming in from time to time. Today, we're going to cover aspects related to health and wellness programs. Now, this is the second webinar in a series of 4 that we're doing each Thursday here in September. Each webinar will explore a different benefit-related topic. Next week, we're going to tackle retirement plans, and the week after will be ERISA litigation. So feel free to join us for either or both of those as well, and you can register for those through the invitation you received for this one. During today's webinar, please feel free to use the question panel at the upper right-hand corner of your screen to submit questions. We do have time at the end of the presentation to answer questions, and we'll address them at that time. Any questions we don't get a chance to answer today, we will follow up with in an email. So with that, we'll go ahead and turn to today's presentation. We're going to talk about 4 different topics today. First, what's all the fuss about HSAs? You've heard a lot about them in the news. There are a few legislative proposals. We're going to spend some time talking about some difficulties that are generating this proposed legislation. Then we'll talk a little bit about what to do with the fact that we don't have any guidance from the EEOC on their wellness program regulations. How do you prepare for 2019 when we don't have the guidance? Third, we're going to talk about how states serving as laboratories can make an employer's life laborious, and that's about as cute as I'm going to get today. But there are a number of initiatives by various states that are impacting multi-state employers. And so whereas we used to have this wonderful reliance on ERISA preempting state laws, more and more we're seeing obligations from the states that are impacting employers. So we'll talk a little bit about that. And last but not least, we'll talk about preparing for 2019, making sure your preparations don't fall through the cracks, both for open enrollment and for plan design for 2019. So let's get started with HSAs. I'm sure you've seen the increased emphasis in the last few years on HSAs. This is a major focus of President Trump's policy, both as a candidate and as a president. We saw in the American Health Care Act, which was the proposed legislation that would have repealed and replaced the Affordable Care Act, some provisions that would make it easier for people to use HSAs. And since that didn't go through, now we've got 2 new bills that have been passed by the House that expand the use of HSAs and also impact FSAs a little bit. We're not going to go through those in detail, but because they're out there, and by the way, we don't anticipate that they'll be taken up by the Senate before the midterm elections. So it's hard to say whether these bills will, be enacted in their current form or any other form. But I do want to point out a couple of issues that you may or may not be struggling with, which then are going to be solved by this legislation if enacted as proposed. So let's start with one example. Let's say during open enrollment, an employee elects to enroll in a PPO and an FSA for 2018. On June 15th, 2018, the employee marries, and he uses his HIPAA special enrollment right to add his new spouse to coverage. Now, the HIPAA special enrollment rights also allow an employee to switch packages. So he decides to move from the PPO to the HDHP. Now, can that employee begin contributing to an HSA? Unfortunately, the guidance that we have would suggest that he cannot. Even though he's switching from a PPO to a high deductible health plan, he fails to be eligible to contribute to an HSA because he enrolled in the flexible spending account for 2018. So he's in a general purpose flexible spending account, which destroys eligibility to contribute to an HSA. So why can't he stop contributing to the flexible spending account and start contributing to the HSA now that he's moved over to the high deductible health plan? Well, it's because we have our cafeteria plan mid-year election change rules, which say that any change to a cafeteria plan election must be consistent with the event that's allowing the change. In this case, we have a marriage. And under the guidance that we have now, it doesn't appear that marriage would be consistent with terminating FSA contributions. I spoke with a representative of the IRS about this issue earlier this year, and that's what he said, that the guidance that we have now just simply wouldn't allow it. And I asked, are you anticipating guidance to fix this issue? Because it's a fairly common issue that comes up with employers. And he said, no, they just haven't gotten enough blowback on it to be working on it.
Yeah, and one of the challenges that I think we end up facing with respect to that, Kim, is probably that the questions we see are those questions that people on the webinar raise to their to their employer.
Mm-hmm.
A lot of this ends up being a personal deduction issue, and it probably is that individuals are making incorrect contributions to HSAs without really discussing or dealing with the individual ramifications of that, because they do have disqualifying first dollar coverage elsewhere. The only times we end up seeing it, the times that you all call us to talk about, is whenever it's raised to an employer level. So it probably exists a great deal more.
That's right.
But it doesn't actually raise to an employer level where we get to the correct answer.
Right. Well, somebody in Congress knows about the issue because the Restoring Access to Medication and Modernizing Health Savings Accounts Act of 2018, that's a mouthful, would allow the employee to convert his FSA balance into an HSA contribution. So essentially, what's left in the FSA becomes an HSA contribution, and now he's eligible to contribute to an HSA for the remainder of the year. So that would be very helpful. David, you want to take the next example?
Yeah, it's really similar to the example, level of the example we were discussing before, because it does also involve marriage. What we end up having is we have two spouses. Spouse is your employee. They are enrolled in a high deductible health plan and making HSA contributions. That means they have no other disqualifying first dollar coverage elsewhere. They get married. Their new spouse is enrolled in an FSA. That FSA, for the same reasons we talked about before, can't be modified as a part of the marriage. So that FSA probably, may not, but probably covers the expenses of not only the spouse, but the spouse's new spouse, thus your employee. And the FSA contribution and ability to get coverage through the spouse's employer's FSA actually destroys the ability of your employee to make an HSA contribution. Now, again, this is probably something that's even less seen by employers than the first example. The first example is whenever an employer comes to you and says, I want to make this change, we're involved in that as an employer. We have the conversations with our employees. This is much more back to our question of the spouse's plan and FSA probably just continues to run from another employer. They have the ability to get disqualifying first dollar contributions, but are still making HSA contributions. This puts the employee or individual in an audit risk much different than the first one, which really is an employer or W-2 challenging question that we end up having.
Right, so here, the employee probably doesn't know this is an issue, so he doesn't raise it with the employer, so the employer probably doesn't know it's an issue.
Right, and so the interesting part of that will end up becoming, though, if this legislation would pass, again, there's an ability to transition those dollars from the FSA into an HSA. We have some employer coordination that's going to be necessary, and the legislation is very short.
Yeah.
And so it would be sort of a question as to how we would deal with some of these factors.
And actually, the legislation would simply say that that employee doesn't cease to be eligible as a result of being covered by the FSA, so long as the FSA doesn't actually reimburse his expenses.
Right, but we're going to have that coordination challenge between two unrelated employers. I do want to spend a couple seconds with respect to the legislation. I think this is important. We have, over time, seen a great deal of pieces of random legislation pertaining to employee benefits, specifically the fringe portions of healthcare. Let's use HSA as an example for that. And the ability to get those passed is very rarely where that bill passes alone. Mm-hmm. These bills become tag-ons to other bills. The chances of this passing actually have to do with, if you look in some of the news, there's conversation about tax reform 2.0. And if there is a bill that is passed before the midterm elections, it will be both a budget bill will pass and tax reform 2.0. Tax reform 2.0 has the chance to be a Christmas tree, where you can take anything that touches taxes and throw it in. Right now, it's actually 3 other bills put together to accomplish, touch a little bit of retirement savings, some individual tax rate issues, and a technical corrections bill. There's a chance that some or any of these type of bills would actually get thrown into a tax reform 2.0. So if it passes, it's likely to pass without any of us really paying that much of attention, because it will get thrown into a bill that within 48 hours is signed into law. So realize that all of these things could possibly pop up real fast, even though we don't see them as a part of an agglomerated working forward healthcare bill, because they really are tax provisions, not necessarily healthcare bills.
And if that happens, it's not as though we're necessarily behind the 8 ball. They're all permissive, right? So it doesn't prevent the employee from being ineligible. So there are things that an employer may want to do or need to do to modify their plan to take advantage of that, but it's not as though it's going to be a scramble to have documentation done in 48 hours. So let's move to another example. Let's say during open enrollment, an employee elects to enroll in a high deductible health plan and an HSA for 2018. Then June 15th, 2018, the employee turns age 65 and is automatically enrolled in Medicare Part A. So let's take a moment to talk about Medicare, because Medicare gets a little confusing when it comes to HSAs. If an individual is receiving Social Security benefits when they turn age 65, they are automatically enrolled in Medicare Part A, effective as of the first day of the month in which they turn 65, or if they turn 65 on the first day of the month prior. If they're not receiving Social Security benefits at age 65 and they don't request them and they don't enroll in Medicare Part B, they're not automatically covered by Medicare Part A. So merely turning age 65 does not disqualify an employee from contributing to an HSA. It has to be coverage under Medicare. And so an employer needs to understand when Medicare applies to know whether an employee has lost eligibility to contribute to an HSA. Once an employee becomes covered under Medicare, whether Part A or Part B, then they no longer are eligible to contribute to an HSA for the remainder of the year. Now, we should also talk about the fact that loss of eligibility to contribute to an HSA doesn't impact the timing of contributions. It impacts the amount that can be contributed to the year. So depending on how your systems are set up, you may terminate HSA contributions when somebody becomes ineligible, but that's not necessarily required, because eligibility impacts the amount of contributions for the year, not the timing. So in our example, we have an employee who turns age 65, must be receiving Social Security benefits because he's automatically enrolled in Medicare Part A. So beginning June 1, he would not be eligible to contribute to an HSA.
Let's talk about the population, and I think this is important, and oddly enough, I know a little bit more about this because of parents, right? We end up sort of dealing with this from a parent perspective. You have an individual who's receiving Social Security benefits before their full normal retirement age, which means they're likely underneath a compensation limitation. So they can't make, and I forget the number, $14,000 a year. So you're talking about likely part-time employees who are approaching 65, who are involved or get coverage from your medical plan. So you can really winnow in on the crowd of people you would otherwise see this issue pop up with. And if you really have a large population of people and want to think about a way to sort of address that, that's your crowd of people. If you don't have part-time coverage for individuals, it's probably unlikely to arise. Not saying it's not factually possible, it's just unlikely to arise. But if you're in an employment setting where you offer part-time employees coverage and you have a large group of people in that what we call phased retirement setting, they've retired from elsewhere, they're drawing Social Security, they're working with you, and they're functionally probably working with you for access to health care. That's the crowd of people you need to winnow in on with respect to HSA contributions for this group, if I were to sort of set a crowd and a group that I'm worried about with respect to these contributions. And
interestingly, if you flip that, the folks who are reaching age 65 and postponing Social Security distribution, postponing Medicare, once they do finally decide to sign up for Medicare or Social Security distribution or Social Security benefits, their Medicare Part A coverage actually becomes effective retroactively up to 6 months before. So you could have an employee who ceases to be eligible to contribute to an HSA retroactively because they have postponed enrollment in Medicare. So it's all sorts of tricky issues here.
Right, and that's going to be a crowd of people that you have that are full-time employees that are approaching age 67 typically, a little bit different with respect to the exact actuarial age that a person has. But so when you're looking at your universe of employees, I would think about them in the space of 65-year-olds that are part-time, 66, 67-year-olds that are full-time, that are inside of your medical plan. Those are the people that you're going to attack with respect to this issue.
And the proposed legislation would allow those folks to remain eligible. So if they're only covered under Medicare Part A because it's automatic and they don't enroll in Medicare Part B, that would not cause them to lose eligibility to contribute to an HSA under this legislation.
Now, we run across one we're seeing more and more. We have a lot more of our employers that are looking at solutions for on-site, close to location, or direct contracts with providers to provide free more than preventative care coverage. We're not talking about flu shots. We're not talking about simple preventative care metrics. We're talking about light coverage, minute clinics, urgent care centers where employers are contracting, or full out on-site locations that will do x-rays, CAT scans, MRIs, depending on how voluminous they want to treat the coverage for employees. Fantastic employee benefit because you're offering ease of access for your employees to be able to get to healthcare. They don't necessarily have to take time away to go. They actually have an incentive when they have a cold to come to work to talk to a PA or a doctor about that issue, as opposed to taking a day and going elsewhere or taking time out of their afternoon or evening when they don't have time. So great employee benefit. The challenge ends up becoming is that if that's free because we contracted with an urgent care provider, because we have an on-site facility that gets beyond preventative care, then that's disqualifying first dollar coverage, because you employee can go to this location, you child dependent can go to this location and get coverage for free. And that free coverage ends up destroying the contribution ability to an HSA, because it means that you end up having disqualifying first dollar coverage. So what we've actually worked with a lot of employers on this issue is there are a panoply of different challenges that come around on-site clinics that are usually outweighed by the benefit, but challenges we have to get through. This is one of them. And really what you end up doing is wanting to make sure you have a very strong list and understanding of what preventative care is, first and foremost. Because if we can fit anything in a preventative care bucket, it can be offered free, and therefore we don't destroy the ability of HSA contributions. Second, we have employers that have to make a decision. And that decision that they're making with respect to is, do they want to charge and worry about this? Some of them have decided they don't necessarily care and will take the risk. We think the better course of action instead is to charge a nominal amount to employees, more than $1, less than 100, not sure exactly what it is, for the service. And so a lot of our clients have ended up charging $25 per visit for a visit to a facility, an urgent care facility, like urgent care-like facility. One of the aspects of the Restoring Access to Medication and Modernizing Health Savings Accounts Act is actually to expand the opportunity. And interestingly, the bill does not just say on-site clinics. It actually expands to clinics, and the language actually says supermarkets and grocery stores among the different places. So really what we're talking about with respect to these programs is the ability of employers in bulk or individually to contract with urgent care facilities to give free non-preventative care services that does not destroy the ability to utilize an HSA. This modification, more than other modifications, I would say that if it gets, and realize these ideas sometimes take a while, really moves an HSA from a vehicle that's supposed to cover your pre-deductible amounts to a vehicle that funds your catastrophic coverage events. And so what the expansion of this is, you can see a doctor, a PA, get light services, but in child breaks an arm, then we're going to end up having deductibles we use in HSA. Unfortunately, somebody gets cancer, then we're going to have an HSA utilization and deductible. But the routine things underneath would then be able to be contracted and outside of an HSA, which is consistent with the fact that we've seen just increasing deductibles that are accidentally approaching the initial limits of what we had for HSA eligibility whenever 2005 was around, and we ended up with the first theory of high deductible health plans.
So, some recommended action steps for dealing with HSAs. Consider what language you're using in HSA enrollment communications and in open enrollment communications. You may want to address some of these issues that we've just talked about proactively in communications with your employees. Consider cafeteria plan language regarding HSA contributions. If this legislation goes through and now all of a sudden you can do some things that you weren't able to do before, you may need to amend your cafeteria plan. You want to consider to address situations where an employee's HSA eligibility is uncertain. For example, you have an employee who calls into a service center and says, I'm enrolling in Medicare, blah, blah, blah. Oh, well, now we have reason to believe that this person is no longer eligible to contribute to an HSA, but he hasn't really told us that. How are we going to deal with that? And then last but not least, confirm that the persons administering the mid-year election changes are aware of the rules applicable to FSAs. A lot of times, the employer doesn't realize, again, that getting out of the FSA is not consistent with a marriage or whatever other life event you have. And so you want to be sure that you're administering your plan consistent with the cafeteria plan election change rules. Moving on then to wellness programs. As you probably know, the EEOC issued some regulations back in 2016 to explain in detail what it means for a wellness program to be voluntary and therefore to not violate the Americans with Disabilities Act. One aspect of those regulations said that if you offer an incentive, a financial monetary incentive, that's not more than 30% of the cost of coverage, we're going to consider that to be voluntary. So it's a safe harbor. We can go up to 30%. And then we have GINA, the Genetic Information Non-Discrimination Act, which says that we can't incentivize our employees to provide their genetic information. Well, when we ask employees to provide information about their spouse's manifested medical conditions, we're actually asking about their genetic information under the definition of the law. And I like to say, if my spouse's medical information is my genetic information, we've done something horribly wrong. I don't think actually that that's it. But the way the law is written and some of the policy behind the law treats the spouse's medical information as genetic information of the employee. And so we are not allowed to incentivize that. Now, the EEOC gave us rules that said we can if we do it in a certain way. The EEOC was sued by AARP, claiming that their incentive regulations hadn't been thought through appropriately, and the court agreed. And there's been some back and forth, the long and the short of it being that these incentive regulations will be vacated effective 1/1/19, which essentially means we no longer have a safe harbor for the amount of incentives that we can provide under a wellness program and still be voluntary and therefore compliant with the ADA. Now, all the other aspects of the rules remain in place, so we still have this general requirement that the program be voluntary, and we still have the requirement to provide the notice. So if you've got a wellness program that involves a medical examination or a disability-related inquiry, typically those biometric screenings and the health risk assessments, you still need to provide that notice. Now, the EEOC knows that these rules are going away, but has not provided any other guidance to help us prepare for 2019. There are a number of reasons behind that we don't need to go into, but the fact of the matter is we don't have it. So what do you do? And our advice typically is this comes down to risk tolerance. Is your company willing to take the risk? We've seen some advice out there that says, oh, get rid of all incentives, and we think that that's probably wrong. So let's take a look at an example. Let's say an employer offers a premium discount to employees who complete a health risk assessment and a biometric screening. The premium discount is equal to 5% of the total cost of employee-only coverage under the employer's lowest cost plan. So clearly this satisfies the 30% rule because we're at 5% instead of 30%. I imagine the EEOC is not going to come in and enforce anything that's under the 30% limit unless and until they issue guidance otherwise. 5%, very low relatively, so probably low risk here that it could be an issue. Now, the fact that the EEOC doesn't come in doesn't mean the employer is safe because we still have this requirement that the program be voluntary. An employee could come in and argue that this 5% discount really is something that's requiring him to provide the health risk assessment because he can't afford the additional 5%. That's an argument, the argument can be made, but 5% likely is very low risk. On the flip side, let's say an employer offers a premium discount to employees who don't use nicotine products. And let's say the premium discount's available only if a blood test confirms lack of nicotine in the system. Now, it's the blood test that pulls the tobacco surcharge or the nicotine surcharge into the EEOC rules. If it's just an attestation, then we don't have to worry about this. We still have to worry about the HIPAA rules, but not the EEOC rules. So because of that, we, under the current rules, could make this nicotine surcharge up to 30% of the total cost of employer and employee, total cost of employee-only coverage. So that's what the employer has done here. They've been as aggressive as they can. When you look at what the employee is actually paying, because the total cost is what the employee and the employer pay together, the employee cost is probably maybe 20% of that. But if you look at the actual incentive to that employee, it could double or maybe even triple the amount that they actually pay. So that very well could be something that causes them to feel like the program is involuntary, which would then call them to complain to the EEOC or to sue. And like I said, I don't think the EEOC is necessarily going to come in for anything that satisfies their rules, But if it's up at the top there, they very well may, especially if you're doing something stupid along with it that would bring in some other ADA charge. So, you know, a design like this, the employer wants to think about, this is a significantly higher level of risk than the example that we just talked about. So, we're going to come back to sort of recommendations in a minute. Before I do that, though, I just want to mention one other thing on wellness programs, which is that the Department of Labor did come out with some guidance on how the FLSA would interact with wellness programs. So in the letter that was written to the Department of Labor, they're looking at voluntary health risk assessments and biometric screening, and truly voluntary under this example. And we're asked, when that employee goes to get the biometric screening, whether it's during work time or outside of work time, is that compensable time under the FLSA? And the Department of Labor said no. That is non-compensable off-duty time under the FLSA. So if you've ever wondered about that, now you know, as part of wellness programs, any time that's treated as participating in the wellness program, you can consider off-duty time. So recommended action steps, in light of the fact that we don't have EEOC guidance, you know, number one, make sure you know if your wellness program is even subject to these rules. So does it involve a medical examination? Does it involve a disability-related inquiry? Confirm the level of incentive that you're offering and consider whether you're comfortable with the level of risk based on that level of incentive. Continue to provide the EEOC wellness program notice and confirm that any changes that you make as a result of this will still comply with the other rules that are applicable to wellness programs, HIPAA and GINA. There are additional rules that we're not talking about today. You want to make sure that any changes you make are still consistent with those rules.
Yeah, and I think that that's important because we've spent so much time just in the community talking about the EEOC's reaction. Realize because a lot of this started because we had coordinated rules from the tri-agency that explained to us how to utilize wellness programs in a HIPAA-compliant means, and expected the EEOC to come along for the ride. And the EEOC decided that they didn't want to come along for the ride, realized that the tri-agency being Department of Treasury / IRS sort of together, Health and Human Services, and being the Department of Labor, the Employee Benefit Security Administration from it, are all presidential appointees. The EEOC is actually run by a presidentially appointed board with some congressional oversight, so it's a different and independent group. So it can ignore and not respond to what the undersecretaries of the tri-agencies are otherwise doing. We ended up having that scenario, and we focused a lot on what the EEOC and how the EEOC reacted. We still have a regulatory agency governing HIPAA with respect to the Department of Labor largely. And interestingly, we're seeing actions from the Department of Labor into smaller employers with 200, 300, 400 employees that have wellness programs, and really digging into what their wellness programs are, whether or not there are reasonable alternatives. One of the things that we kind of felt for a while, at least I kind of felt, is that there was some anonymity in being small. I can be a smaller employer and offer a wellness program because all the actions against wellness programs had been against large employers. That's no longer true. We're seeing Department of Labor actions against plans with 120 employees. And so it's a time to think about not only how do I want to comply with the EEOC, maybe it's time to think about it and making sure I'm complying with the HIPAA side of the house when I hadn't necessarily as well as I could have complied with the HIPAA side of the house.
All right, moving on then to state initiatives. Now, something else that's causing a lot of pain for employers are state-based leave laws. We're not going to talk about that today. Today we're going to focus on the rules that are applicable to health plans. So as you may know, probably know, the individual mandate under the Affordable Care Act is being reduced to 0 effective 1/1/19. And there are some states that are a little nervous about that because without the individual mandate, there's a risk that we enter into a death spiral where only the people who are sick then purchase insurance, which makes insurance more expensive, which reduces the number of people who are willing to pay into insurance, which makes insurance more expensive, and so on and so forth. And so without an individual mandate, without getting more people paying into the system, there's a fear that the system will just destabilize. And so you've got some states that are dipping their toe into the water to try to prevent that. Now, Massachusetts has had an individual mandate for many years. New Jersey has enacted an individual mandate that will become effective 1/1/19. And Vermont has enacted an individual mandate that will become effective January 1, 2020. Now, with these individual mandates come employer reporting obligations, because the state needs to know whether an individual actually has enrolled in the coverage that they're required to enroll in order to avoid a penalty. So Massachusetts, we currently have the 1099-HC. New Jersey has not yet issued guidance on exactly what form their notice requirement is going to take. The statute says that it can be very similar to what you do for ACA reporting purposes, but again, we don't know exactly what that'll be. And Vermont hasn't really put any color around their requirement. That's something that they're building this year. So something to watch is making sure that you know what your reporting obligations are to the various states. Now, in addition to state-imposed individual mandates, we have kind of an employer mandate being started by a state here as well. And I say kind of an employer mandate because, as you'll see in a moment, even if you comply, that doesn't protect you from the potential for having to pay. So Massachusetts has an employer medical assistance contribution supplement, which was added this year. It's temporary. It's effective only for 2018 and 2019. And so you're required to pay this extra amount if you have at least 6 employees in Massachusetts, you've got an employee who's not disabled and earns a minimum of $500 in a quarter, and that employee enrolls in any of the following coverages for more than 56 days in a quarter. It could be subsidized Massachusetts marketplace coverage, it could be Medicaid, or it could be CHIP. So if you've got an employee who enrolls in any of those coverages, you could get this contribution. The contribution that you must pay is equal to 5% of the employee's wages, but the contribution would never be more than $750 per year per individual. So what happens is you would submit your wages online for purposes of unemployment insurance, and then the Massachusetts Department of Unemployment Assistance takes a look at that, figures out which of your employees have enrolled in one of the 3 coverages, and then assesses the supplement. So you can actually go online if this is assessed and see the detail about which employees are triggering the contribution at UI Online. Now, you can request a hearing within 10 days of receiving a notice of the contributions. That's not a lot of time. But what's even more important is that the reason that you can dispute the charge is very limited. You can argue that you don't have 6 employees. You can argue that the person who's triggered the penalty is actually an independent contractor and not an employee. You can argue that the wages that were reported weren't for unemployment insurance purposes. Or you could argue that the employee wasn't actually covered for at least 56 days. What you can't argue is that you offered affordable minimum value coverage. That's not going to get you anywhere based on what we've seen so far. So let's take a look at how this compares to the Affordable Care Act. You know, if you offer affordable minimum value coverage to your employee, the employee voluntarily waives your coverage and enrolls in Medicaid for at least 56 days. Under the Affordable Care Act, no employer mandate penalty, because it's all about what you offered. You made the offer of affordable minimum value health coverage, and the employee just chose not to take it. So you as an employer are fine. However, under the Massachusetts EMAC, the mere fact that they enrolled in Medicaid triggers the supplement. The fact that you offered the coverage doesn't get you out of it. Similarly, let's look at this. Employer offers affordable minimum value coverage to employee, and the employee goes and enrolls in subsidized coverage through the Massachusetts marketplace. Now, theoretically, that employee shouldn't be able to get a subsidy if you've offered them affordable minimum value coverage. So under the Affordable Care Act, there should be no penalty because you've made the offer. And you have the right to appeal the marketplace's determination, assuming you get a notice of it. And you've got a right to sort of work with the IRS and prove to the IRS that you did offer affordable minimum value coverage. And despite the fact that they said they didn't have it and they got the subsidy anyway, you should be off the hook. However, under Massachusetts EMAC, again, the fact that you offered it doesn't eliminate the contribution. So the employee enrolled in the subsidized coverage, there's no opportunity to appeal that through the Massachusetts EMAC. I mean, you may have to go back and do it through the connector, but here, you know, it appears that you're sort of stuck. So something to watch. In addition, we have, unrelated to mandates, just wanted to spend a moment on the New Jersey law on surprise out-of-network bills. Now, we've seen a number of states try to enact protections against surprise out-of-network bills, and that's where you go to a hospital that's in your network, and you have a surgery done by a surgeon that's in your network, and you expect that all of your expenses are going to be network expenses. But that anesthesiologist that they brought in is out of network. And so you get a bill and a balance bill from the anesthesiologist for those out-of-network services. In New Jersey now, they've established this law that would protect you from that being balance billed. But that really applies to, insured plans in New Jersey. Now, New Jersey is giving self-funded health plans the opportunity to opt into this law to protect their employees. But in order to do that, you have to agree to a binding arbitration. You have to provide annual notice to New Jersey. You have to amend your plan documents and SPDs. And it's not entirely clear what benefit the plan gets from this, what benefit your employees really get from it. We have no guidance yet on how to elect in. We have no guidance on what that means. So even though this law went into effect at the end of August, there's not a lot out there on electing self-funded health plans. So recommend that you keep your eyes open for this, but there's really not much you can do at this point. So recommended action steps, just make sure you know what states your employees live in, and you know what state-based obligations you have to comply with. Any reporting obligations, you want to make sure if your administrator or insurer isn't taking care of it that you are. Watch for that Massachusetts EMAC contribution, see if there's any opportunity to appeal if you feel that it's wrong. Watch for guidance on new employer contributions or reporting obligations in the future. If you've got a self-funded health plan, and if you're interested in the New Jersey law, keep a watch out for guidance, and we'll see what other states do in the future.
Yeah, I don't think that we're likely to see states stop experimenting. One of the challenges that we ended up seeing is that there were two directions during the Affordable Care Act and sort of our healthcare reform debate. Was we could go entirely to a federal solution and pull states away, or we could use what was called states are the incubators of ideas. The challenge with respect to states being the incubators of ideas is they're the incubators at the expense of you employers. So it's one of those spots that you have to keep apprised of where you have employees, where your employees both practice and live. So it's not only where your offices are, where they actually live can end up being a factor, and how your plan's going to interact with them. Because I don't think we're going to stop seeing state laws, especially from the coast, but they'll work their way inland as we end up seeing more and more of these laws pop up.
And localities. You've got San Francisco that has its employer spending requirement. And actually, the city of Seattle enacted an employer mandate on hotels that had more than 100 rooms, and required that those hotels provide their employees with health coverage that was at least as good as the gold level standard on the Washington Exchange. And ERIC, the ERISA Industry Committee, sued for preemption, arguing that ERISA preempted it. And Seattle has actually offered to stop imposing this mandate while the lawsuit's going on. So, it's not just states. We're starting to see it pop up all over. Well, let's move now to preparing for 2019. As you prepare for open enrollment, know that most of the model notices haven't changed. So there's not a whole lot you need to do to update many of these for 2019. The CHIP notice, however, has been updated. It typically is updated twice a year. So you want to make sure you're using the governmental model. July 31st, 2018 is the most recent update. Remember that the CHIP notice, though, needs to go to all employees who are living in a state that's listed on the notice. So if you're only putting your CHIP notice in your open enrollment materials, and your open enrollment materials are only going to people who are eligible for your plan, you're missing some of the population that needs to get this notice. And there is a penalty for failure to provide the notice, so it's something you want to watch. Now, you may have seen the president signed an executive order relatively recently to address retirement plans. And in that executive order, one of the things that he asked was that the Department of Labor reevaluate the ability to provide electronic notices for retirement plan notices. I thought it was interesting that it was limited to retirement plans, because we have the same issue with welfare plans, but maybe that's just the focus of the executive order. So we know that the electronic distribution rules are antiquated. The Department of Labor has a general rule that ERISA required materials must be distributed using measures reasonably calculated to ensure actual receipt. And they've got a safe harbor that says if you do these things, then it's reasonably calculated to ensure actual receipt. So if you get consent and you follow the consent rules, that's fine. Or if you're sending it to a person who accesses your computer system as an integral part of their job and is able to access your computer system for wherever they're reasonably expected to work, You give them notice, you're willing to give them a hard copy for free, you know, it actually is received. If you get the bounce back, you make sure they get it. Follow those steps, and that's deemed to be acceptable distribution. Now, that's the safe harbor. Does that mean that's the only way you can give electronic notice and be okay under the Department of Labor standards? Theoretically, there's you know, something outside of that on the Venn diagram. We've seen the Department of Labor be a little bit more strict on that. Practically, most employers are taking the risk and being more expansive on what they're willing to do with electronic distribution.
Yeah, and what we ended up seeing, which was an oddity, is that as a part of the Affordable Care Act, so many of you know we have the SBCs, the Summary of Benefits Coverage. This is the 4-page document with charts, formats to compare your plans to other like-kind plans, trying to make health plans look more qualified, make them so I can compare one spouse's plan to another spouse's plan. Oddly enough, we were told we could do what's called postcarding that. So we're allowed to actually send a postcard to people telling them where they can access the SBC online. Interestingly enough, would not comply with the safe harbor requirements for the Department of Labor. And on top of, interestingly enough, probably more important than every other notice we otherwise provide to people generally. And so we've had a lot of employers that have basically said, if that document, which is seemingly so important to the decision-making process of individuals, is able to be sent via a postcard, meaning I can send a postcard or an email to individuals and tell them where they can get that document, shouldn't the rest be considered safe harbor? One of the conversation points actually I've had with individuals in Treasury, in the service, and at the Department of Labor with this is that they're concerned about writing a regulation with respect to the delivery of, with the electronic delivery of notices because technology moves so quickly. By the time they would actually get a regulation published and final, the technology has surpassed where they would otherwise be. And so it's the thought of, do you just pull it away and say, we don't care reasonable, and we'll litigate what reasonable is, or do we try to create a standard where we're getting to a point of loose nature of basically these are what your rules are? My guess is we'll probably end up nowhere if I were to actually give some acquiescence, but I think that what we could potentially end up seeing is that we go to reasonable with updates from either a website, oddly enough, or really loose field assistance bulletins issued functionally to the community as to how things can be delivered. A great example of this is we have not yet talked about the ability or means to deliver documentation via social media. We're going to get to that. We're going to get to a place where you can send a message via Twitter, via text, via Facebook, or whatever the next thing is. The next platform we don't even know is. And that's going to end up being a conversation point about how we end up delivering some of these notices through those vehicles. And so as we approach and deal with, I think it's probably going to be a little bit looser standard that the community just kind of says, we believe this to work, as opposed to a more hard standard of what the old regulation was.
And this all applies to Department of Labor guidance on ERISA required notices. But there are some notices that have different distribution requirements and actually say when electronic distribution is okay or not okay. So it's important to note if you're sending out your notices all electronically because you feel like you can under the Department of Labor safe harbor, it may or may not be okay under these other notices. The most stringent one is the HIPAA notice, where you can't send the HIPAA notice out electronically unless you get consent from the employee to receive HIPAA notices electronically. So the safe harbor doesn't work there. But thankfully, the HIPAA notice only has to go out every 3 years, and you don't actually have to send the whole notice again. You can just send a reminder of the availability of it. I want to just remind you about this concept of endorsement as you're preparing your enrollment communications. If you have voluntary insurance products and you take the position that they are not subject to ERISA because employees' participation is completely voluntary, they pay the full cost of it, you do nothing other than allow the insurance company to come in, set up shop, sell to your employees, and take the payroll deductions and remit it to the employer. You're not endorsing it. Then it can be a non-ERISA benefit. But the key is, what does it mean to endorse it? Endorsement is all based on facts and circumstances and can include things like putting your logo on these communications, telling your employees that you are offering this benefit to them. You know, the way you promote or communicate about this benefit could turn it into an ERISA plan. And just that does not to say that you can't communicate about it in open enrollment or with your open enrollment materials, but you need to be careful about the way that you do it. Slightly separately on the same topic, you also want to be sure that you're not endorsing it through the certificate of coverage that the insurance company issues. And I know you're thinking, well, what sort of control do we have over that? A lot of times an insurance company will allow you to sort of tack on the SPD at the back of the certificate. And that's exactly what happened in a case this year, Stolbarger versus Prudential. It's based out of the Northern District of California. And you had an employee who was suing their long-term disability insurer under a voluntary policy offered by their employer, and making state law claims, claiming that ERISA did not apply because this was a voluntary product and the employer did not endorse it. And what the court found was the certificate of coverage that had been given to the employee had an SPD attachment to it. And it said, this policy is governed by ERISA and your employer is offering it, and da-da-da-da-da. And so it was that certificate of insurance that tipped the scales for the court and said, oh, yes, this is a federally covered product. It is an ERISA product. And so state law claims are going to be preempted. Now, that's great news for the insurance company, and the insurance company wants it to be an ERISA benefit because they get the protections in litigation. Bad news for the employer who thought they were offering a voluntary product and weren't filing 5500s or, complying with the other ERISA obligations. So keep that in mind. From a coverage perspective, as you're designing your plan for 2019, you want to be sure that you're aware of the limits that have been updated. Keep in mind that non-grandfathered plan out-of-pocket maximum for a family coverage, you cannot apply more than $7,900 to any individual. So you've got to have that embedded out-of-pocket maximum. So watch your numbers here. We know what the affordability percentage is going to be. So as you're looking at what to charge for 2019, make sure you know how that relates to affordability under the Affordable Care Act. And then last but not least, I want to mention a couple of coverage topics. One is mental health parity. We know we got some guidance earlier this year from the Department of Labor, some proposed FAQs. We got some reports from the Department of Labor about their enforcement activities. We got some reports from the Department of Health and Human Services on mental health parity. And this was all coming out of the 20th Century Cures Act, which was passed at the end of 2016, which instructed the agencies to provide more information and more guidance on complying with the mental health parity rules. So the Department of Labor has issued a warning signs publication. You can go through that and say, do I have any of these plan designs in my plan? And if so, I may need to go one more step to figure out whether this plan design is compliant with the mental health parity rules or not. The harder part about mental health parity compliance is figuring out whether your administrator is complying. And that's a whole nother topic for a whole nother day. But when you're looking at plan design, you want to make sure that the things you've decided to cover and the way you've decided to cover them are compliant with the mental health parity rules. For example, ABA therapy. It is perfectly fine under the mental health parity rules to say we're not going to cover any services for a particular condition. We're not going to cover anything for autism. But once we start covering services for autism, anything we exclude, we should have a reason why. We should be able to say under the mental health parity rules why that exclusion is compliant with the mental health parity rules. So we've seen a number of lawsuits on ABA therapy. ABA therapy is a big issue, especially with employees. I know employers hear a lot from their employees who say, we want this covered. So if you're not covering it, you should be prepared to explain why. We've also been seeing some lawsuits recently on wilderness therapy, and not necessarily that the plan excluded coverage for wilderness therapy and that was an issue, but that maybe the administrator applied a non-quantitative treatment limitation to exclude that. And then the employees arguing that the way they did that, the way they characterized the wilderness therapy is not compliant with the mental health parity rules. So a couple of hot spots to be looking at. And then we've got coverage of gender transition services. So we know Section 1557 of the Affordable Care Act prohibits health plans from discriminating against individuals on a number of bases, including sex. Section 1557, though, only applies to covered entities, which are health programs or activities that receive funding from HHS. There were some regulations issued that said if you are one of those covered entities, you can't have a blanket exclusion for gender transition services. Now, those particular regulations, the issues on gender transition, have actually been enjoined. So they're not enforced right now. But that then raised for a lot of employers, oh, what are we doing with gender transition services? If you're subject to the OFCCP rules, prohibit discrimination on the basis of sex. And there's language in those rules that say you can't have a blanket exclusion for gender transition services. And if you have one of those, then you jeopardize your right to get federal contracts. Beyond that, we've got Title VII. Title VII prohibits discrimination on the basis of sex. Well, is gender transition, sex? It's a discrimination against a transgender individual, discrimination on the basis of sex. We're seeing some court cases say yes. We're seeing the Department of Labor leaning that way. So although that's not yet been decided, that is a significant risk. If your plan is not covering gender transition services, it's something to think about. So recommended action steps: confirm which notices are required for you for 2019. Make sure you are providing any annual notices as required. Update any applicable dates in those notices. You want to confirm that your open enrollment materials don't accidentally endorse any non-ERISA voluntary insurance. And of course, you want to confirm that your certificates of coverage are not doing that either. Confirm that your 2019 plan design satisfies the updated limits. Make sure you know if it's affordable for purposes of the Affordable Care Act. Work with your insurer administrator to confirm mental health parity compliance relating to non-quantitative treatment limitations in addition to the plan design elements that we've talked about. And confirm the extent to which your plan will cover ABA therapy, wilderness therapy, and/or gender transition services. There are other hot spots out there, but those are the ones we just wanted to talk about on the webinar today. So that takes us to the end of the prepared presentation. We'll now begin a Q&A session. If you'd like CLE or HRCI, note that there's an attachment on the right side of your screen, right above where you type in your questions. So you'll need to print that attachment, complete the attorney affirmation form to receive the credit. You'll also need to include a code on the form, and the code is TH, that's T as in Thompson and H as in Hine, 913. So again, that's TH913. Also, if you'd like a copy of the slides, they are in that attachment area as well. You are welcome to download them there. And after today's session, you'll receive an email with a very brief survey about the webinar. It should only take a few minutes to complete, and we'd really appreciate it. We'd love your feedback on the presentation and how we can help in the future. So now let's move into the Q&A session. Go ahead and type your questions into the question box, and we'll address them as they come in with the time remaining.
Yeah. So the first question we have, Kim, is pertaining to spousal acknowledgement required by GINA when genetic information may be collected as a part of a biometric screen or an HRA. First, any thoughts on collecting that electronically? And second, how much of that's being delegated to wellness providers, or is it being handled inside of the HR departments and plan administrative function inside of the company?
It's a good question, and we tend to recommend our employers that they handle it themselves unless they've specifically addressed that with their vendor. Sometimes the vendor will do this electronically. The health risk assessment is online. And so somebody has to click through a couple of screens in order to get to the health risk assessment, and the authorization might be there. That seems like a reasonable way of obtaining that authorization from the spouse. But it is something to note, again, because this is genetic information, and with these incentive rules that we have, the spouse actually has to provide consent before they give their medical information. Now, those rules are vacated for 1/1/19, so or I should say the incentive rules are vacated, but the requirement to provide consent for genetic information is not. So I would recommend that you continue to obtain, if you're going to continue to provide incentive for spouses to complete health risk assessments, make sure you're getting their authorization beforehand.
Okay. Another question that came in: when an employee is hired mid-year and elects an HSA, do we have an obligation to ask whether the employee is covered by a spouse's FSA?
So this goes back to what you were talking about with the fact that the spouse's FSA could destroy eligibility to contribute to an HSA. And I don't know that there's an obligation for the employer to do that. Now, certainly, if the employer becomes aware of that fact, now we've got an issue, because when an employer makes an HSA contribution on behalf of an employee on a pre-tax basis, the employer is allowed to treat it as a pre-tax contribution unless they have reason to know that it would be taxable. So if the employer has reason to know that the contribution is taxable, then they either don't make the contribution or they treat it as taxable wages that has to be reported in box 1 of the W-2. And then, of course, the employee would have to withdraw that to avoid the excise tax. But so long as the employer doesn't have reason to know, I don't think the employer has an obligation to go snooping either. So employees who are hired mid-year, there's not necessarily an obligation to ask them, what other health coverage do you have? I think if they come in and they elect the HSA, that's probably good enough. Although I would recommend enrollment communications have some sort of language that puts a burden on the employee where you assert that you are eligible to contribute to an HSA. And that way, if there are ever any questions, you know, we've sort of put the onus on the employee when it's really their onus anyway.
Right, but this is the counteract to the question that you had dealt with in the examples previously, where an employee moves from an PPO with an FSA to an HGHP with an HSA.
Where we know
and are administering
yes.
both sides of that program.
That's right.
So.
That's right.
So another question came in. Have you heard anything about guidance with respect to health reimbursement arrangements?
No, not recently. As of May, I know that it definitely was being worked on, so I'm sure it's still being worked on. And this goes back to the President's executive order, one of his first executive orders, where he wanted to make it easier for folks to use health reimbursement arrangements, so HRAs. Right now, under the Affordable Care Act, an employer can't offer a standalone HRA. It has to be integrated with other health coverage, and there are requirements, hoops you have to jump through in order to do that. The sense that I'm getting from what we've been hearing at ABA tax section meetings is that that integration requirement may go away, or it may be considerably eased. But I have not yet heard if there's any sort of date by which we can expect that guidance. As of right now, HRA compliance is status quo.
So we had a question on sort of the coordination between PPO and high deductible health plans. And basically the question is it getting so complex that employers are beginning to choose, or should they start choosing a lane, either a PPO or an HDHP? Or if they stay with respect to both of them, should they eliminate an FSA option because the administration of an FSA in coordination with an HSA is too challenging?
I mean, should is a good question. That's going to go to, you know, what sort of administration the employer is willing to put into it. I mean, the rules are what they are. They haven't changed in a relatively recent while, and so you can get your hands around them. I have seen employers say enough is enough. I'm just doing one, and certainly that is a valid way to go. But I don't know that we're at the point yet where I'm definitely not recommending that.
So in that scenario, if you have employers that the PPO option, you can still offer a limited purpose FSA because that would not require the coordination on the other side with the HSA. And so you can get to a little sort of light spacing there, but it doesn't seem to me that the getting rid of an FSA entirely comes down to a little bit to a use question.
Right.
How much of your employees are utilizing this?
Mm-hmm.
I always stress to people, and I think this is really important, any of those modifications, if you have any union employee population, are likely subject to bargaining. And so making unilateral changes with respect to the elimination of a program could very well end up in an LRB charge if it does not come through a labor bargaining session. So it's really important to deal with and make sure you cover those portions. So one last question. Somebody had heard a proposed law that would eliminate the employer mandate. Can you talk a little bit about where we stand on ACA and the employer mandate? Right.
So the ACA is still the law of the land. There is proposed legislation that would provide relief on the employer mandate from 2015 through 2018. So not repeal it altogether, but at least provide some relief through 2018. And it would also delay the Cadillac tax for another year. So moving from 2022 to 2023.
Which is interesting. Will they make Cadillacs by the time the Cadillac tax is in effect?
It's this one, unless it gets tacked on, unless it gets hung on the Christmas tree, probably not going anywhere anytime soon.
Well, want to thank everybody for their time. If we can read the code one more time to make sure that everybody has the code for the CLE and CE forms. That's
right. So the code is TH, T as in Thompson, H as in Hine, Thompson Hine, TH913. So thank you all for attending our webinar today. Please take a few minutes to complete the evaluation. Remember, if you want your CLE or HRCI credits, you must complete and remit the attached form to us as directed. Thanks, everyone. Have a good afternoon.